Hello friends, welcome to my channel again. Today we are going to see what is scapular dyskinesis. Scapular dyskinesis is either the abnormal resting position of the scapula or the abnormal movement of the scapula. So before going out into the what are the abnormal movements of the scapula, we will see what are the normal movements of the scapula. These are the various muscle attachments on the scapula. First is the anterior view, second is the posterior view. So let's suppose this is the midline like this. Midline means the spine is there. This is the spine, and then here will be the ribs like this. Ribs will be like this. So what will be the movements are, first is the elevation. Elevation of the scapula is by the levator scapulae, which is attached here, and the trapezius, upper fibers of the trapezius, which come like this and attach here. So these two muscles cause the elevation of the scapula. Then is the depression of the scapula. Depression of the scapula is caused by the lower fibers of the trapezius, which come from the spine like this, and the lower fibers of the serratus anterior, which come from the ribs like this, and they depress the scapula. The third muscle causes the depression of the scapula is the pectoralis minor, which comes from the upper ribs, attaches like this and pulls the scapula downwards, and it causes the depression of the scapula. So these three muscles cause the depression of the scapula. Then we will see the protraction of the scapula and retraction of the scapula. Protraction of the scapula, as you all know, is caused by the serratus anterior. Protraction is the movement of the scapula away from the midline like this. In anterior it will be like this, and in posterior view it will be like this, away from the midline, which is the protraction. And retraction is movement of the scapula towards the midline like this. And protraction is caused by serratus anterior, and retraction is caused by mainly the rhomboid minor and major and the middle fibers of the trapezius. Rhomboid minor is attached here like this, rhomboid major like this, and over both of them is the trapezius, middle fiber of the trapezius. These three muscles cause the retraction of the scapula. Then we will see the external rotation and internal rotation of the scapula. External rotation is the outward movement of the scapula. Internal rotation is the inward rotation of the scapula along this axis, which is centered here. The scapula will move either externally or internally, internal rotation. So what are the muscle causing these movements? First will be the trapezius muscle, upper fibers attached like this, and upon contraction they will move the scapula like this, external rotate the scapula. Then is the internal rotation. Internal rotation is mainly caused by the rhomboids, which move the scapula like this. They cause both the traction and internal rotation of the scapula. And the other muscle causing the internal rotation is the pectoralis minor. Pectoralis minor in addition causes the anterior tilt, which is the main pathology in scapular dyskinesis. In scapular dyskinesis, in the normal movements of our arm, the scapula retracts and it external rotates and it tilts posteriorly. Posterior tilt. This is the anterior tilt. But when the pectoralis minor is tight, it causes the anterior tilt of the scapula, and the normal movements is hindered. During normal scapular movements, the scapula tilts posteriorly, it retracts and it external rotates. But if the pectoralis minor is tight, what it will cause? It will cause the anterior tilting and internal rotation of the scapula, which is pathologic. So we have almost seen all the movements of the scapula. Now we will see what are the muscular causes of scapular dyskinesis, and these can be treated non-operatively. First, which muscles are tight? First of all, the major culprit is the pectoralis minor, and along with it coracobrachialis can also be tight. So how to diagnose it? The patient will be having coracoid tenderness because the pectoralis minor is attached there. So we can diagnose it when the patient is having coracoid tenderness. So the second muscle is the latissimus dorsi. The latissimus dorsi tightness can be suggested when here and here there can be tender points within the latissimus dorsi. Similarly, upper trapezius and rotator cuff tightness can be there. It is mostly the reduced internal rotation of the shoulder, which is the GERD, glenohumeral internal rotation deficit. It is not possible to cover that in this video. It can be taken in another video. And then coming on to the weak muscles. Weak muscles, first starting from the core, because for your scapula to contract and work properly, your core should be working properly. If your core is weak, scapular dyskinesis can be there. Then it is the upper, middle and the lower trapezius. All these three muscles can be weak, and what will happen if these are weak? The scapula would not retract properly. Then the rhomboids. Rhomboids also cause the retraction of the scapula. And you know already that in normal scapular movements, scapula retracts, it external rotate and it tilts posteriorly. So rhomboids help in retraction of the scapula, which is the normal movement of the scapula. Then the serratus anterior. Serratus anterior, if it is weak, the inferior-medial angle prominence can be there because it is attached there and it causes the external rotation of the scapula. If external rotation of the scapula is not there, there will be internal rotation of the scapula and inferior medial angle prominence will be there. Then coming on to the what are the operative causes. First is the long thoracic nerve injury. It can lead to medial scapular winging. So actually it is not called as scapular dyskinesis, it is called scapular dyskinesia when it is due to a nerve injury. Then it can be scapular muscle detachment, can be snapping scapula, clavicle fracture, acromioclavicle joint injury, rotator cuff tear or labral tear. All these needs a surgical intervention. Then coming on to the type of scapular dyskinesis. These are clinically not that important because the management doesn't significantly differ, but for the naming sake, type 1 inferior angle prominence is there, type 2 medial border prominence is there, and type 3 superior medial angle prominence is there. Some also consider type 4, which is symmetrical bilateral scapular dyskinesis. So we will see the various scapular dyskinesis here. Let's see. Can you see the dyskinesis here? Which side? First see which side and then which type is there. See it again. As you can see here, this angle, inferior medial angle prominence is there and it is type 1 dyskinesis. Then again on the left side, inferior medial angle prominence is there and again type 1 dyskinesis. Ask the patient to move up and down 3 to 5 times. Here which side is involved? It is right side. As you can see here, inferior medial angle prominence is there and it is type 1 again. Now here again inferior medial angle prominence on the right side here. Now this is the scapular resistance test. I am pushing the medial border of the scapula forward and there will be pain relief. Now guess which type is this? It is type 2 scapular dyskinesis. As you can see beautifully, the medial angle prominence is there. Here you can see the medial angle is prominent here and it is type 2 scapular dyskinesis. Here again it is a combination of type 2 and 3. I haven't seen a classical type 3, but it is 2 going on to 3. Again type 2 and type, you can see type 3 also, because the spheromedial angle prominence is there also. Now this is the scapular resistance test. I am pushing the scapula forwards, the medial border of the scapula forwards. The position of the scapula has normalized and the pain is also relieved. Now this is the scapular resistance test. The power is too much weak. Now the power is also increased and the symptoms have also improved. Now what is this kinetic chain? As I have told you before, for your scapula to work properly, your core should be stabilized. As you can see in this picture, for this boy to throw this ball, first which muscle of his body would be contracting? Yes, you guessed it right. Here the gastrocnemius muscle is first contracting, then the hip stabilizers, then the back extensor, then the abdominal muscles, then the scapular muscles contract and stabilize the scapula, and then the rotator cuff muscles come into action, and then he can throw the ball. So that's the reason first your core should be functioning properly, and then you go on to the rehabilitate the scapula. Now how will we rehabilitate the scapula? As I already told you, first we will see if there is weakness of the core. How can we see this? We can ask the patient to do single leg standing and single leg squats. These two things most probably we can detect the core weakness, and you can also see the exaggerated lumbar lordosis. When it will be there, it means the iliopsoas is tight and there is anterior tilting of the pelvis. Now for the scapula, first we should release the tight structures. So what as we already discussed, which are the tight structures? Anteriorly the pectoralis minor, and it can be coracobrachialis also, and then it can be the latissimus dorsi. These are the two most affected tight muscles. This is the corner stretch. Corner stretch you can do it like this. Ask the patient to stand at door and keep the arm like this and push your body forwards and stretch the pectoralis minor and the anterior shoulder structures. Second is the latissimus dorsi stretch. As you can see, ask the patient to do it like this, stretch towards the other side, and your latissimus dorsi will be stretched. Then the strengthening of the weak muscles. This is the low row exercise. So we ask the patient to keep his hand like this and push the stairs or the wall posteriorly, and this helps in strengthening the serratus anterior and the lower fibers of the trapezius. Second is the lawn mower exercise. This is how lawn mower exercise is done. Ask the patient to hold a 3 kg or 5 kg weight and then do the maneuver like this. This will help the scapula to get the normal retraction. Then is the robbery position. It can be either static or dynamic. It will cause the retraction of the scapula and it will strengthen the rhomboids. This is the robbery position. This is 1 week follow-up of the patient, of the last patient with scapular dyskinesis, and as you can see that almost 90% improvement of the dyskinesis is there, but the patient was totally symptom free, no pain was there. So these are the only 3 exercises which will help strengthen the scapular stabilizing muscles and will help to rehabilitate the patients with scapular dyskinesis. If you like this video, kindly like, subscribe and share, and see you in next video. Thank you.